plexus. Remember, all you have to do is follow that subclavian artery and put a little margin around it, and then you'll miss the brachial plexus and hopefully avoid a long-lasting problem. So just to sum up, the brachial plexus is important. The main thing to do is to look for that anterior scalene muscle. It's usually the easiest of all the structures to see, and know that a little bit below that has to be the middle scalene muscle. And I would just go ahead and contour both the upper and lower parts of that and use the subclavian artery as a landmark when I get to the lower portion. So help your doctor out and contour that. And let me show you some examples of how I would contour the brachial plexus, because I think it's simpler than the other methods that you're going to find published. So all that I suggest that you do is you can easily figure out where C5 and T1 are. Just use your laterals and other things, and then just follow the nerve out as it leaves the vertebral body. This is your brachial plexus root, and don't worry about when it becomes anything else, a trunk, a branch, or anything. Know that this is your anterior scalene muscle. This thing down below it is going to be your middle scalene, and just contour this whole thing in between, and don't worry about whether it really should stop here or here or here. I mean, if you're a super veteran, you can go ahead and do that, but our goal is just to prevent an injury, and so I just contour that whole space, and that makes life easier. I lost my ability to move. And so as I contour on down, I just keep doing the same thing. I follow the spinal cord out. I've got my anterior scalene muscle that I can see really well. It's a little harder to see the middle scalene muscle, and I just follow it on down. And when I can't find anything leaving the spinal cord, I just fill in that space between those two muscles, the anterior and the middle scalene, and just follow that on down. And as you keep going, well, good. There's another place I can see the root leaving the spinal cord. And I usually just set my little brush to about 5 millimeters or so, and I just push it on through, and I just fill in that whole space as I go down. And I just use this same method, tracking all the way through, where when I can see the nerve root, I go all the way up against the spinal cord. Otherwise, I just sit in between that space between the two scalene muscles. You know, it's really not hard. It's a whole lot better than a 9 and 10-step method. And, you know, you're not going to hurt anybody if you do this. And just follow it on down. Okay. And now I'm just going to follow my blood vessel. I've got my nice subclavian artery here. I can just follow it on out. And again, if I make it a little big, that's okay, because the main thing is not to hurt anybody. And you can follow this on out the arm as much as you want. Remember, if you've got a patient with the arms down, if the arm's up, it's going to move the top part of the brachial plexus over a bit. So again, just follow this great big blood vessel. I really like to have my simulations done with contrast, and I think it's too bad that they gave you a set that didn't have contrast, but that's how life goes in the world of contouring challenges. But when you can see the blood vessel and it's all nice and white, it's not so hard to contour it. You can do this, you know, it usually takes about 5 minutes to do the brachial plexus on each side. I think most patients are worth 10 minutes of work. And so that's how I suggest that you contour the brachial plexus. Do you have to do the question?
Neil, I believe Dr. Wheeler is pretty much finished with his presentation. If you want to move on to the next part, or do you want to do a Q&A session now?
Let's see here. I'm going to take control here then. There are a couple of questions that came across. Why don't we just have, I know that Dr. Wheeler doesn't have all the time, so if we could just have him answer maybe these few questions that came across right now, I think that'd be good. Question, are you stating that IMRT is now conventional head and neck treatment? Greg?
Do you want me to
Doctor?
do the test questions that
No,
wanted me to
no,
ask?
I've got a few questions here from participants that they would like you to answer if you can.
Okay. Put it on speaker.
And first one is, are you stating that IMRT is now conventional head and neck treatment?
Could you repeat that question?
Sure. Are you stating that IMRT is now conventional head and neck treatment?
When I talked about conventional treatment, what I was saying was conventional head and neck treatment was 2 lateral fields and an AP field. Now, as we're doing more and more IMRT, I hardly ever do anyone with conventional fields, but certainly in the world of trying to get insurance approval, when I talk about conventional fields, they mean 2 lateral fields with a superclav field, and when I mean anything else, I say IMRT.
Great. And I think you answered this question while you were talking, but do you routinely give your patients contrast to aid in the contouring of the brachial plexus, which I believe you were saying that's the way you'd like to see it because you can see the blood vessels better.
Yeah, without contrast, it's easy to fool yourself on where the subclavian artery is, and I like to have contrast on all of my head and necks. Also, if there's a patient who's got lymph nodes, it's easy to think a blood vessel as a lymph node and put it in as a gross target volume, and certainly you don't need to take the common carotid artery to 70 gray, and if you had contrast in it, you'd see, oh yeah, that's a blood vessel. And so I personally give IV contrast to every head and neck cancer patient that is not allergic to contrast or has some other medical reason to not be given contrast.
Okay,
but
wonderful.
We'll argue with that.
I just want to remind people, use that Q&A section if you do have questions. We'll try and get those answered. Actually, one just came across. What is your tolerance dose for the brachial plexus?
Yeah, if you look classically, it's stated to be around 50 gray. We know that in the neck, we can routinely give it 60 gray. The whole idea of what the tolerance dose is really a matter of debate. I would just try to avoid giving anything greater than 110% hotspot in the brachial plexus. I think if you do that, it's okay. With stereotactic radiosurgery, I don't think you want to give more than 7 or 8 gray per fraction for a total of 24 gray to the brachial plexus, or you're going to risk having trouble. You can easily give 6 gray times 4 to the brachial plexus. I think if you try to do anything more than that, you're going to get in trouble with the big dose per fraction.
Great. Thank you. There was a question that came across actually earlier. This was actually, John, right after you got done talking, so I might just pose this to you because I think it might have been going towards you. Do you use MRI fusion during contouring for CMDs?
Sometimes certain sites we will use MRI, but for this particular study we did not. It was all CT based.
Okay. Dr. Wheeler, anything you want to add to MRI?
MRI is the best way to see the brachial plexus, especially if you have a T2 stir sequence. But, I almost never have a patient who's had an MRI scan who has head and neck cancer. All of our planning is done off of either PET, CT. It's usually they have a PET CT or they just simply have an IV contrast simulation CT. But I rarely have patients who have MRI scans of the head and neck area. And so that's why I want to use easy CT viewable landmarks like the anterior middle scalene and the subclavian artery, because that's what I can actually see. If I had a beautiful MRI sequence, sure I would use it, but I don't ever have that.
Okay. Thank you. I don't see any other questions at the moment. Ben, you saw one?
And what main source book do you use?
Sorry, one just popped up here. What are you seeing, Ben? I'm missing whatever you're seeing.
In the chat window.
It's in the chat window? Oh, I'm sorry.
Go ahead.
I'm sorry, somebody just pointed out, there's a question here. What main source or book do you recommend to use for CT anatomy?
At the end of the talk, the test questions came, and they wanted me to wait until later on to present those. There's a set of references, and it tells